So, a very good evening to all. I'd like to thank Brilliant Medical and the guys from China for giving me this opportunity to give this talk on microwave ablation, the Singaporean experience. These are my disclosures relevant to this talk. So, as an introduction, endovenous ablation has a recommendation of 1B from the SVS and AVF guidelines for endothermal ablation of varicose veins, and as well as from NICE guidelines from the UK, and it's basically considered the first choice over foam and surgery, and therefore, and if there's no surgery, then stockings. Where non-thermal ablation holds, we still don't really have that data, and then that is yet to be recommended where it fits in these guidelines. However, there's good data based on efficacy, safety, and quality of life. So basically, you close or ablate a superficial axial vein. However you do it, does it actually really matter? So these are the categories of endovenous ablation for varicose veins. You've got your thermal tumescent techniques, including the now lot of data, level 1 evidence of laser, whether with whatever type of laser wire that you do. There's radiofrequency ablation, using 3 different types. There's steam, which is not as well known, and we don't have it here in Singapore. And now microwave has fitted into this kind of category, and we've been using it for the past couple of years. We also have non-thermal, non-tumescent techniques, such as mechanical chemical ablation. That's using the Claridane device, which now belongs to Merit Medical. We've got Cyanoacrylate Glue from numerous companies now, which seems to be the favored kind of ablation technique, although the evidence is still very much out there. And obviously foam included into this category. So radiofrequency ablation is what most people are pretty familiar with. There's now 15-year data from my good friend Mark Whiteley from the UK, with excellent clinical success, with 100% satisfaction rate, and reinterventions are very low, and recurrences are very low. So why do we actually need another ablation technique when this technique actually has proven long-term and it actually does the job? There is recent data from the European Journal with a randomized controlled trial affecting 3 different radiofrequency technologies, all showing relatively, in a large number of patients, good outcomes. But the fact is that there is early failure at 6 months with one of the types, and even some has put to the stage whether we should be ablating these veins even very closer to the junction. However, a lot of these RFA devices, and one of them specifically, I won't name it because it belongs to the company, it's just basically a hot rod. It does not cause transmural cell death, goes right to the adventitia. So that's why you get that recurrence rate if you don't get good apposition of the catheter against the cell, against the wall. And you can see with RFA application, you've got to compress the vein against the catheter to get a good effect, and you may have to treat it 2 or 3 times, but you do get that recurrence rate. With laser and with RFA, you do get ecchymosis, and you can get significant bruising, and there's always the risk of nerve damage, albeit low. And you do need to use compression stockings, although no one really knows for how long. But this is not very well tolerated in countries like from Singapore with a temperate climate. And actually compliance rate can be as low as 10%. So we wrote a letter to Phlebology recently suggesting, do we need another modality for vein ablation? And we considered microwave as we started using that at Singapore General and at National University Hospital, the other university hospital in Singapore. We did a modality indicator for varicose veins from all the vascular specialists from the Vascular Society in Singapore. And this is recent data from our hospital. And basically the majority do use RFA laser and open surgery still, quite surprisingly. And glue, though, has become very much come to the fore, especially in the private sector. And you can see what people consider the important, and really the important thing is how the venous pattern of disease on Duplex, as well as the anatomical findings. We did a recent study with Kathleen Gibson from the US looking at anatomy between Caucasian and Asians, looking at the superficial venous anatomy as well as the reflux patterns in quite a significant number of patients. And basically what we found was Asians present with higher SEEP scores. Asians have more total GSV reflux, as well as reflux within the small saphenous vein than Caucasians. And the diameters at all levels seem to be larger in Caucasians compared to Asians. And this is kind of the CVI spectrum. We can be a bit more advanced stage on presentation. And sometimes with these types of skin, they're not great for thermal tumescence. Glue, as I said, has become a very popular modality for use because theoretically you can do the ablation through just one micropuncture incision. And there's Turkish glue available as well as the more established VenaSeal from Medtronic. And what you can do and the advantage people see through that, it can go through a difficult field, a bad skin, and you can basically avoid nerve damage, especially in the small saphenous vein territory. However, these glues have problems, and you get this VenaSeal red reaction that was described when this thing started. And you can see it can happen any time after surgery to at least a year after surgery for no apparent reason. And you do get the odd number of cases of glue rejection where you have to excise the glue, and these are the remnants that have come out basically of the patient that gets infected. Also, if there's an N3 vein, the vein is on the surface, which we see quite a lot of suprafascial extensions in our Asian population in Singapore. You get a cord pulling effect, and that's what we've shown with our ASVS data from the use of VenaSeal at 1 year. So what are the principles of microwave? Well, the temperature with microwave is about 85 degrees, and you compare that with a laser, which can be over 1,000, and radio frequency is about 120 degrees. So theoretically, there should be less risk of thermal damage, especially risk of nerve injury and ecchymosis. So which veins should you be using for microwave? And I think this answer very much comes from what we have found is that the C2, the larger veins, is ideal. The larger truncal veins in the thigh is actually an ideal for EMA. And the setup, I'm just going to go through this with you because I think, I'm sure people want to know how to do this. So the thing is very similar. So you map it out, you prep them, the patient stays in a supine position, you map out where you're going to do your phlebectomies, and you find a way to puncture the great saphenous vein. And typically, I always puncture below the knee. The longer length you get, I think you get a better result. And I use a micropuncture technique to get in, and you typically need a 6 French sheath to actually put the device through, which is actually smaller than some of the other devices that are on show. And you place the sheath, and typically you map out the vein, and you get that in, and you flush it. Looking at this EMA antennae, you can see, importantly, that there are these markings. There's 1 centimeter markings on it, and there is actually markings to show when actually it gets back into that sheath, and also how many centimeters from the end of the catheter. And typically at about 3 centimeters, I tend not to do any more ablation and then pull out the catheter. And the settings I'll come to in a minute, and typically you need a tumescent pump, and you connect it to that machine as you go. And as you can see, typically you put it around 2 centimeters from the saphenofemoral junction. And for the sapheno-popliteal junction, I typically take it beyond the fascial curve so it doesn't dive into the muscle. Okay, so that's very much similar to what we do with most of the other techniques. And then we infiltrate a cocktail of anesthetic along the vein. So this gives you a tumescent sink. And that's my cocktail that I use over the years, and I've not really changed. And I basically hook the catheter into place so that when it moves, it doesn't move, and you lose position when you put tumescence in. And you put a good amount of compression around the vein, around the probe to improve heat transfer. These are the needles I use. I use the barred BD, either the spinal needle, for those who are done under local anesthetic, so you reduce the number of theoretical punctures along the vein, or I use a 19 gauge if the patient's asleep and I want a lot more, I want a more infiltration around the vein. And I typically do this with a longitudinal technique to minimize the number of stabs that you would give the patient. And you do this virtually all under ultrasound guidance. And this is the Tumescent Anaesthesia, and you see this kind of halo around the catheter, and the catheter is very easily seen, and I think it's actually better seen than actually the RFA catheters available. You confirm the final position, and then you can start heating the vein. Now, what do I do here? When you can see that there is a mark there where I'm pointing to with the little dots, that's when you need to remove the sheath, otherwise you'll burn the sheath. And obviously measurement of where you go in. And it's 1 centimeter pullbacks. And this is the protocol we pull, and there's a little pump. And basically there's a pedal that you press. You don't even need to even compress the catheter against the vein. And this is very different from RFA, whereby you have to get good apposition, good contact, and avoid charcoaling of the catheter tip in order to get a good effect. And for microwave, especially for the bigger veins, I think this is an excellent way and more durable way and more satisfying way of dealing with the vein. And this is the protocol that I use. I used the Whiteley protocol. I set it at 40 watts, and each one of those, and burn it for 7 seconds for each centimeter treated. I treat the proximal 5 centimeters twice. If the diameter of the vein at the top is more than 10 millimeters, I increase the seconds used, not the wattage, as we've seen from previous data. And you basically watch the vein to coagulate. And it basically contracts down. And if it doesn't contract down on the ultrasound, I'll give a 3rd cycle. If the vein is very close to the surface, and people will always wonder about that vein, even though it's in the thigh, you can push it off the surface of the skin, and you can be confident to block it and avoid any kind of skin burns. For that kind of reason, I may turn down, I keep the wattage at 40, but may reduce the number of seconds down to 5 seconds. And very much like laser, you can actually tailor it where you want to go. And that's all you're left with, a little 6 French sheath puncture at the site or where you go in. And then you do your phlebectomies afterwards. And I typically use an Ursha hook to do that. And I stitch them up because I think in Asian skin, you get a better cosmetic result. And I'd remove the stitches in about 1 week. And the patient goes into a 2-layer compression, and that comes off when I see them next at my clinic, which is typically 5 to 7 days after the surgery. And if they want to wear compression, I have no kind of telling them to wear it for 2 weeks. And in fact, a lot of them don't like wearing compression hosiery. And sometimes that's the reason why they like glue. It's because glue doesn't require them to use compression. But this is not, I don't dictate this. And I think I've got some very good results without compression. This is my post-procedure care. I ask them to wear it for 24 hours, followed by the optional stockings, typically for 5 days, resume normal activities, and no strenuous aerobic activity for 1 week. And these are some of the duplex scans that we see, thrombosed. And actually, sometimes you don't see the clot within the vein. Actually, the vein is non-compressible and there's no flow through it earlier on. And you can see this is 1 week post-EMA in this lady, minimal bruising, and the vein completely blocked off. And as you can see, even the side branches have been taken out. And I was very impressed. And this lady was very happy and mobile almost immediately. Another patient, the GSV blocked at 1 week. Again, you can see minimal ecchymosis, minimal bruising with EMA. This is another one with MSA. And you can see, funny enough, more of the bruising is actually from the phlebectomy sites rather than from the microwave ablation. So our initial experience with EMA or SGH, you get less post-op pain, bruising, and swelling. Patients tend not to use any compression hosiery, which is a great advantage in temperate climate. And even with some of the bigger GSM, we treated up to 20 millimeters, it is very effective. And then the important thing is you don't need to collapse the vein onto the catheter. We've also taken the experience further, and we've used it for venous ulcers. Now, a lot of people don't tend to take an RFA or even a laser catheter right down to the ulcer because they worry, especially below the knee, about how close the saphenous nerve is to the great saphenous vein and the risk of nerve injury. And we've done this in a number of cases now, CEEP6 disease, and we're taking it right down and ablated it, and you can see a very good effect. We've had no numbness and no nerve injuries using this thing, using the EMA device for this. I've kept the protocol very similar. I have not turned down the power or the number of seconds to each centimeter is treated, and you get a good effect. And sometimes you can reverse the catheter and go retrograde underneath the ulcer bed to actually ablate the small plexuses under there using this device. It's very floppy. Unfortunately, there's no wire that you can put the thing on if you've got very tortuous veins, and you may need to use a double puncture effect, like I see in that middle picture, to deal with the below knee vein. So I'm just going to quickly touch on the Maestro study that we were running at SGH, along with my good friend Julian Wong from National University Hospital, who contributed to this study. And basically, it's a pilot study looking at the efficacy and safety because it's not HSA ready yet in Singapore, so they need local data. And we looked at technical success, anatomical success, and complete closure at 3, 6, and 12 months. This is the trial flow, and we did quality of life measures. And basically, we used VCSS, ABQ, Civic, and EQ5D. And very unusual that we use multiple quality of life, but that's where things are heading towards in terms of varicose veins, where everything is now patient-centric and how satisfied they are. We looked at pain scores over the first 10 days and return to normal activities. Just quickly turning to patient demographics, the majority, over to about 72%, were Chinese, all were ambulatory. The typical age, around 60, and a mean BMI of 26. The majority, as usual, are females, about in 60% of cases. Those are the comorbidities. Majority of these was ASA class 2. CEEP category, we did the majority with CEEP2S. We included some CEEP6 patients in the end for this, who were quite symptomatic. These were the procedural characteristics. So in these 36 patients, which is interim results, we do have up to 50 patients. We did bilateral in about 13%, and we treated all GSVs. And average time of treatment once you basically started the ablation was about 5.5 minutes. We did concomitant phlebectomies in about 50%, and how we decided that is we did that with the patients. My threshold for phlebectomies has come down. The very small ones, I think, will disappear if you ablate low enough. At 6 months, very credible 100% occlusion rates, which is in keeping with a lot of the literature. It's what happens after that. The important thing about this device, and I think that's something that's a selling point, is that there's not much residual bruising at 3 months, no cases of numbness, even if you take the catheter right down and towards the foot. In terms of procedural details, the majority of my punctures, and about two-thirds were actually in the proximal calf and mid-calf. The lower you go, the longer vein you ablate, I think you get a better result. You can see the pain scores were low even actually on day 0 actually, and they significantly improved by 2 weeks. And these pain scores, if you look at the data from the VenaSeal data, from the different registries, especially although we ran our ASVS data registry, they're actually comparable to the non-thermal, non-tumescent techniques. Return to activities, very good, about 45% resumed daily activities on day 1. Now, patients don't tend to return to work because they normally get what we call a hospital leave certificate, normally for a week, and they tend to take as much leave as they want. So it's a different kind of process. People don't tend to want to go back to work. So I think that can be skewed in some way from this data. But you can see by 10 days, 100% resumed daily activities, and about 36% went back to work. And as you can see, quite a lot did not wear compression stockings for any of the time post-operatively and still had a good result. And you can see from the clinical measures, much improvement in the EQ5D and the AVQ and civic. And this typically happens from the drop between the 2 weeks and the 3-month period. Although we can't really explain why the civic score went up at 6 months. But generally, there's an improvement in all aspects of quality of life. In terms of patient satisfaction, and this is kind of a questionnaire that I use for most of my venous studies, and I think it's very useful to see what kind of satisfaction patients get. You can see by 6 months, they're very satisfied in the majority, over 80%, and symptom control much improved by 2 weeks. And you get that effect when you ablate that vein. Just quickly, I'm sure my next co-speaker will talk about it, so I won't speak too much. This is really much the only comparative data there is currently, and it comes from China. We're looking at the microwave against laser ablation for varicose veins, and I won't mention too much of this. I'm sure he will. I think we're going down the line of personalized medicine for varicose veins, and I think you have to tailor it to how the patient is, what type of patient it is, and the venous anatomy. So I think the future of thermoablation is the future of endovenous ablation. I still think there's a role for this, and I think for the bigger veins, I would rather have this done rather than putting glue or a non-thermal technique with a potential foreign body in the vein. And one of my favorite singers, Bob Dylan, says, "Time will tell just who fell and who's left behind when you go your way and I go mine," which means that a lot of these patients, a lot of physicians will choose, and ultimately they will have a choice. And I think you should have both a thermal ablation technique and a non-thermal ablation technique in your armory for dealing with varicose veins. And in that, I thank you and I hand you back to the chair. And I'll be delighted to take any questions. If you have any emails, send it to me. I'm very happy to answer your questions. Thank you very much for listening.